and I'm really excited to be talking with you about the neurocritical care patients that we take care of in the emergency department. We're going to be talking about these 4 topics, and I'm going to focus on what's important for us to know and what's new. Some of the other topics, we could go into depth in any one of these topics, and I want to put something out there for next year's conference. We're thinking about putting on an emergency neurology life support course as a pre-conference. So if you're interested in that and you would be interested in having that course, please put that in your evaluation or get that information to us somehow, because we need to have enough people to put the course on. It's a great course that goes into more depth on these kind of topics. So let's start off with subarachnoid hemorrhage. It was July, it was hot, it was busy. I was in the ED with a bunch of new residents, running around like crazy, and I got a phone call on my cell phone. It was a very good friend of mine. 8 weeks earlier, she had given birth to her 3rd child, and she and her family were traveling in another state, visiting family. They were at the zoo, and she got a really bad headache. She doesn't usually get headaches. And so she said to her husband, I'm probably dehydrated. Got something to drink, got something to eat, and the headache didn't go away. And she said, you know what, maybe we should go back to the house. If I lie down, this will probably go away. And so she headed back, they were in the car, and then she all of a sudden threw up. And she said, maybe we should go to the emergency department. And they went to the emergency department, and they got triaged, and she sat there for a couple of hours before she called me. And she said, it's just a headache. I feel like I should just go back to the house and go to sleep and this will go away. Or take some ibuprofen or something. And I said, no, you should stay and get evaluated. Because I was thinking about this, the aneurysm. We needed to prove in her that she didn't have an aneurysm rupture. She had a sudden onset headache in a person who doesn't get headaches and who's otherwise healthy, and we needed to rule that out. So I called into the department and I said, hey, I know you guys are busy. We're all busy too. And a friend of mine in your waiting room has a headache. I've already talked to her and said, you're probably going to get a CAT scan, and if it's negative, you're going to get a lumbar puncture, and she's good with that. And he said, okay, yeah. He brought her right in and got her a CAT scan. Now, I'm going to give you my bias. I work in the neuro ICU, so I see the bad cases. I see the young women who come in and had an aneurysm rupture, didn't get diagnosed, and then it got worse, and then they came in when the second headache started, and it's devastating. So I have this bias. I'm very particular about subarachnoid hemorrhage. It's a low-frequency, high-acuity problem. 1% of people who come to the emergency department come for headache. 1% of those have a subarachnoid aneurysm that ruptured. 50% of those have a completely normal neuroexam. Now, when the first rupture happens, mortality is 25%. There's another increase in that mortality if it doesn't get treated. So by 1 or 2 weeks, it's going to be 40%. But if that re-ruptures, mortality goes up to 70%. That's the really bad part of this. So if we miss the diagnosis on the first go, and it re-ruptures, which there's a 1.5% chance every day that will re-rupture. If that happens, mortality skyrockets. That's why I call this a low-frequency, high-acuity problem that we can't afford to miss. And that's why I'm so particular about it. So how do we not miss these without doing a lumbar puncture on every patient who comes through the door with a headache? Because we don't really want to do that. And this is my method. There's 2 questions that we need to ask. The first question is, what was the onset of the headache? Was it sudden or gradual? Do you remember when it started, what you were doing? Was it a particular point in time? Now, in the literature, sudden is defined as up to 1 hour, which doesn't really feel very sudden, does it? But we know from data that we're collecting at Yale that people who end up having subarachnoid bleeds, it happened right away, within 5 to 10 seconds, maybe even 15 minutes. So this is a question you need to figure out by pulling the stool next to the bed, listening to the patient give you their story. And you're thinking the whole time, was this sudden or was this gradual? Was this a headache that started a few days ago and it just hasn't gone away and that's why you're showing up in my emergency department? Or did it have a distinct onset? The second question is, what kind of headache is this? Are you somebody who never gets headaches and now you've got a really bad headache? Are you somebody who gets migraines once or twice a year and now you've got a headache that's really different from that migraine? Are you somebody who gets 3 or 4 migraines a month and this is very different from that headache? So you see, you're trying to dig this story out. And those are the two important questions, is was it sudden onset or gradual, and was it different from your normal headaches? Or is it a headache that you never get? Now, this is one of our study patients. He obviously has blood in his head. His story went like this. It was 9 o'clock in the morning. I was in the bathroom washing my hands, getting ready to go down for breakfast, and I got this headache. It was so bad, it was disoriented. I just wanted to lie down and make it go away. I felt like my head was going to come off. That's a pretty easy story. That's somebody that all of us would say they need to go in the subarachnoid hemorrhage pathway. Now, sometimes you get this guy who says, "You want to know about my headache? Ask my wife. She knows everything about my health." Do I ever get headaches? Ask my wife. She knows everything. I mean, this is a difficult patient. We've seen this guy, all of us. He comes in not infrequently. He's tough. He's a really tough historian. So in these cases, you may just have to be conservative and say, I'm putting this guy in the pathway because I can't really tell from what he's telling me. Now, my friend had an episode of vomiting. If the headache is associated with vomiting or loss of consciousness or a clouding of consciousness, that patient is 1.5 times more likely to have a subarachnoid bleed. Exertion. If the headache's associated with exertion, they're 2 times more likely to have a subarachnoid bleed. So think of those as red flags. Now, exertion can be this guy who's lifting these puny little weights. It can be somebody sitting on the toilet trying to have a bowel movement. It can be sex. It can be anything that's exertional to the patient. But think of those red flags. Now, this is what I'm calling the pathway. The pathway starts up on the top with the non-contrast CT. If it's positive, you're done. If it's negative, you have all the choices below. We'll talk about the 6-hour rule, the lumbar puncture, which is our standard of care, the CTA, which many people are starting to like, the MRI, which we really don't talk about that often. Ultimately, you have to come to a decision. Does this patient have blood in their head or not? Am I going to send them home? Am I going to keep them there? Let's talk about the 6-hour rule. Perry put this rule out. He published this in 2010. And essentially what it said was, if you've got somebody with a sudden onset headache that you're worried about subarachnoid hemorrhage, if you scan them within 6 hours, it's 100% sensitive, 100% specific. People loved that. That's great. All we have to do is scan them. We've got our answer. We don't have to worry about that lumbar puncture. There's some caveats to this, though, that I want you to be aware of. These are the criteria that they used for this study. And if you're applying the 6-hour rule, these should be the criteria that are present in your patient's case as well. Needs to be accurate timing. So the guy who wants you to talk to his wife about his headaches is probably not a good candidate for this 6-hour rule. It needs to be isolated headache, no neck pain, no meningismus, a normal neuroexam. That means anterior and posterior, Romberg, tandem gait, heel to shin, papilledema. 3rd generation scanner or better, no motion artifact in the image, cuts should be 5 millimeters or less, and the crit should be greater than 30, because if it's less than 30, you may not have enough blood to show up on the CAT scan. The reading radiologist does not need to be a neuroradiologist, but it needs to be somebody who reads these every day very frequently. And you should tell them, I'm looking for subarachnoid blood. I've got a patient with a sudden onset severe headache. At the end of the day, if all these criteria fit and your CT is negative, there is still a 1 to 2 per 1,000 chance that the patient still has blood in their head. So be careful when you're using this, if you're using it, because these are required criteria. And you might say, why are you being so picky about all these little details? And I say, because it's a low frequency, high acuity problem. And we can do well by our patients if we don't ever miss a subarachnoid hemorrhage. What about the lumbar puncture? This is our standard of care, but there's issues with this as well. First of all, it's painful. Patients don't like it. Many of us don't like it. It takes time, and you can have complications. Rare complications, but you can have post-dural headache, bleeding, infection, nerve damage. It's possible. Probably not likely. What about if you get blood in the CSF? We don't have a good way of saying whether blood in tubes 1 through 4 is a traumatic tap or true subarachnoid blood. It's been studied. People have looked at it. What are the numbers? How much do the numbers decline? And I've seen cases where the numbers declined very significantly. Person still had a subarachnoid hemorrhage. So that's really not that reliable. Perry did this study. He looked at a subarachnoid hemorrhage rule that I'll show you later. And he took that database and he looked back at it and figured out in the 4th tube, if there's less than 2,000 times 10 to the 6 red blood cells, and there's no Santha Chromia, it's 100% sensitive. So this isn't validated yet. It's not prospective, but I think it's something that we can look forward to that will be helpful when we do our lumbar punctures. What about Santha Chromia? Santha Chromia takes 12 hours to present in the CSF if you want to be 100% sensitive. Some centers are actually admitting patients so that they get past the 12-hour mark before they do the lumbar puncture. So even though if you get a CT that's negative and a lumbar puncture that within the limitations is negative, that's the best test we have to rule this disease out. But there's a lot of limitations to it. What about the Ct Angiogram? I give this talk in other places and I get a lot of people coming up to me saying, I just do a CT. If it's negative, I do a CTA. If there's no aneurysm, I'm sending them home. I'll be honest with you. There's folks in my shop who do this. But I'm not a fan of it, and I'm going to explain to you why. When you get a CAT scan, a non-contrast CAT scan, you're looking for blood. When you get a CTA, you're looking for an aneurysm. Those are two divergent strategies. They're each looking for something different. That's not a good strategy to figure out if your patient has subarachnoid blood. The CTA is not 100% sensitive. It can miss up to 2% of aneurysms. It can miss aneurysms that are less than 2 millimeters, and those bleed. So using that strategy has a lot of cons and not that many pros. It's intuitive and it seems to make sense, but it's not the best strategy if you never want to miss a subarachnoid hemorrhage. So my friend went into the emergency department there. She got a CAT scan. It was negative. And they said, you have a cluster headache. We're going to give you some oxygen and some analgesia, and then we'll send you home. And she went home with a headache. And a couple of days later, she was back home. And she called me, and we were talking about it. And she said, I still have this headache. I don't know how to feel about it. I don't know if that was really the workup I needed. I said, it absolutely wasn't the workup you needed. We did not show that you don't have subarachnoid hemorrhage. And your story is classic. And we talked about the mortality if she should rebleed. So she decided to come back into the emergency department at home. And my colleague did an MRI, MRV. They did an MRV because she's 8 weeks postpartum and they wanted to rule out a venous thrombosis, which I think was very smart. That was negative. The MRI was negative as well. They invoked neurology, talked about the case, and decided, listen, we're 3 days out from the onset. As the CT sensitivity goes down, the MRI sensitivity goes up. And so 3 days out, if you have an MRI that shows flare and SWI images that are negative, you've ruled out blood, and you're done. Now, I'm not advocating for MRI when you first see the patient when they come in the door. First of all, it's not good use of resources, and it's not even as accurate as we want it to be in the first hours. But in this case, it was fortuitous. She did okay, it was negative, she went home, and she's still okay today. So there's a good ending to that story. This is the Ottawa Subarachnoid Clinical Decision Rule that the Perry Group put together. And if you look at this, any of the criteria here rules you into going down the pathway. It's 100% sensitive and 15% specific. So I feel that if you used this rule, you might end up doing more lumbar punctures than you would otherwise. It's not validated yet. There's a couple of other centers that are piloting it and testing it, and we'll see where it goes. But that's the clinical decision rule. We still have our guidelines. ACEP guideline from 2008, Heart Association, Stroke Association from 2012, both say the same thing. If you're worried about subarachnoid hemorrhage, you get a CT. If it's negative, you should do a lumbar puncture. And that's where we are. I think these will change with time as our technology advances, but for right now, that's our guidelines. I believe we should be using shared decision-making when we approach this problem with our patients. Some people would disagree with me and say, oh, this is too complicated. The patients can't possibly understand all the intricacies of subarachnoid hemorrhage. I disagree. I think that's the art of our profession, is being able to take complicated medical knowledge and boil it down to something that a patient can understand and relate to. And we need to document our decisions, our conversations, and how we got there. So what if you find that needle in the haystack? Well, there's just a few things you need to do. First of all, lower the blood pressure. At our shop, we lower it to less than 140. I don't have strong data for that number. 140, 150, you want to bring it down. The theory is decrease the hydrostatic pressure. That's going to increase the risk of re-rupture, because that's the goal, is avoid re-rupture. Reverse coagulopathy, whatever it is, vitamin K antagonists, platelets, antiplatelet agents, NOACs, do whatever you can to reverse coagulopathy. Think about seizure. 20% of these patients may have seizure, and they deserve an anti-epileptic load. Phenytoin, Keppra. If they have a lot of blood, if their neuro exam isn't perfect, if they're not AO by 3 and interacting with you and following commands, they may be having subclinical seizure. Think about hydrocephalus when you look at the CAT scan. 20% of patients who have subarachnoid hemorrhage will have hydrocephalus, and they need a ventriculostomy. So, at the end of the day with subarachnoid hemorrhage, consider who needs the workup. Put the right patients in the pathway, and it'll help you to be accurate. Understand all the limitations of the tools that we have, and use shared decision-making. So I want to take a poll. How many people here live in a state where you don't see snow and ice in the winter? All right. I'm sorry for that. And I want to take you to New England, where I have a house. My husband and I have a home in Maine. And this is pictures from this past Valentine's Day. We looked out the window and we saw a lot of snow. We actually got about 4 feet of snow in the 2 days prior to this. So I got a new shovel for Valentine's Day, thanks to my husband, with Christmas gift wrapping, because he knew that we were going to be putting the ladder up and cleaning the snow off the roof. Of course, I didn't get the fun part of going up on the roof and pushing the snow off. That's my husband pushing the snow off of the roof. And this is me at the bottom, shoveling all the wet, heavy snow that came off the roof. And that's a big pile of snow. And that is me trying to smile, because that was back-breaking work. But don't let me scare you off from coming up to New England. All right. Let's talk about traumatic brain injury. This is a patient I saw a few months ago. He's a young guy, 32 years old, and he worked as a tree surgeon. He was not the person up on the tree. He was on the ground, and he got hit by a big limb. He came into the department. EMS couldn't intubate him. He was unresponsive, and we intubated him, and during that intubation, he became bradycardic. So we quickly got him to the scanner, and we saw this. He's got a left-sided subdural with 10 millimeters subdural with 13 millimeters of shift. And you can tell by looking at this CAT scan that he doesn't have a whole lot of space. This is a young, healthy brain. Not a lot of space to expand. So this is a bad subdural. And if this is him. If you had an older person, if you had an older person with a lot more space in their brain, they could sustain a subdural that's this big. This is an MRI. And you can see that this subdural really had no impact on the midline. But that's because they have all this space surrounding. But he didn't have space because he's young and healthy. So we have to think about traumatic brain injury. It's a heterogeneous, complicated injury, and it comes in many different flavors. You've got subdural, epidural, parenchymal, diffuse axonal injury, and traumatic subarachnoid, and intraventricular. They're all the same as far as how we treat them. The Brain Trauma Foundation puts out guidelines, and they just put out some new guidelines, which is good because we haven't had new guidelines since 2007. But really, it's hard to change any of the guidelines, and to be honest with you, these guidelines haven't changed that much from what they were in 2007. But I'm going to go through, and we'll talk about the principles of what we need to know to treat traumatic brain injury and go through this case. The most important thing is to avoid hypotension and hypoxia. And I think this is probably the most significant change in the guideline that we have. This study out of Arizona looked at 3,000 patients, and they had pre-hospital data and emergency medicine data showing blood pressures from the moment EMS got to the patient. And, you know, we used to say, don't ever let the blood pressure fall below 90 systolic. But now we're saying it needs to be higher than that. And indeed, the guidelines are higher than that, and I'll show you this. But with this study, they showed for every 5 millimeters of incremental increase in blood pressure, all the way up to 135, there was improved outcome. So this is not validated, and it wasn't. It's not ready for prime time yet. But it tells us that blood pressure needs to be higher in TBI, higher than even what we thought before. So the guidelines now are saying if you're between 50 and 70 years old, you want your blood pressure to be greater than 100. If you're less than 50, greater than 70, it should be greater than 110. So that's probably the most significant change in the guidelines. Remember how traumatic brain injury fits into the other neurologic disasters that we see with respect to blood pressure, because we all perseverate about blood pressure in neurology, right? With hemorrhagic stroke, you want to lower the blood pressure. And you heard Haney talking this morning about the ATTACK-2 trial. We don't exactly know where we want to lower it to. It needs to be less than 180 for sure, maybe less than 140. With subarachnoid hemorrhage, we want it to come down quickly, less than 140, less than 150. But ischemic stroke and traumatic brain injury want more blood pressure. So, we're targeting cerebral perfusion pressure. That's why we want more blood pressure. If you increase your mean arterial pressure, it will overcome the ICP that's trying to squeeze down on the cerebral arteries. So what you're doing is you're preventing stroke by keeping the blood pressure up. But we really don't usually have the benefit of a ventriculostomy to tell what our ICP really is. So we have to use our judgment. And we have to say, we need that blood pressure to be up. We're looking at the exam, we're looking at the scan, and we know that the Brain Trauma Foundation wants the cerebral perfusion pressure to be 60 to 70. So you want to think, if the ICP was 20, that guy would be talking to me. So it's got to be more than that. Maybe it's 25, maybe it's 30. So I want my mean arterial pressure to be 90. I want to push it up there. So it's a little bit of deduction. Other things we can do. If they have a C-collar on, don't have it really tight. Loosen it up a bit so that you get jugular venous outflow. When you're intubating the patient, and even afterwards, keep the head of the bed up at least 30 degrees. All of that improves venous outflow and helps ICP. Well, what about after you've intubated this patient? Do you want to hyperventilate? And the answer for our patient was absolutely, because he had a really bad scan, and he had a really bad exam, and he was headed to the OR to get a craniectomy. So I can take his skull off, well, not me personally, but we can take his skull off, and he's got all kinds of room to swell. You don't want to hyperventilate patients just routinely. You want to know that they're going to definitive care. Whether it's putting a ventriculostomy, they need to have some kind of pop-off valve, because hyperventilation has long-lasting effects. And in the first 24 hours of a TBI, the cerebral autoregulation is not intact. So it's not a good time to hyperventilate unless you're headed to something definitive. We need to reverse anticoagulation, whether it's vitamin K antagonists, platelet inhibition, the novel oral anticoagulants. We need to reverse that. Now, I know Haney talked this morning about the PATCH trial, and I just want to remind us that this is not for TBI. The PATCH trial applies to intracerebral hemorrhage spontaneous. So anybody who's on antiplatelets has TBI should get a pack of platelets. Think about seizure prophylaxis. All severe TBI, according to the BTF guidelines, should get prophylaxis for the first 7 days. And it can be phenytoin, it can be Keppra, it doesn't matter what it is. Load them in the emergency department, we'll continue it upstairs for 7 days. What about osmotic therapy? Yes, it works really well. Now, in the emergency department, we're stuck with not knowing what exactly the ICP is. But by clinically looking at this patient who's unresponsive, who's bradying down, who's got a terrible CT, I know there's a component of edema going on there, and he's got shift, and he's got some herniation that's starting. I'm throwing everything at him, and osmotic therapy is one of the things. So you can use mannitol, you can use hypertonic saline, you can even use an amp or two of sodium bicarbonate that you have in your code card. Any one of those will work. Mannitol is the favorite. It's been around forever. It's been studied more. But the risk with that is it causes diuresis, and you could drop the blood pressure without wanting to. So I like hypertonic saline. 3%, 7%. If you have a nice line, give a 23% bullet, we call it. You can even give both, and I've done that before as well. What about ventriculostomy? Who should get a ventriculostomy? Well, with TBI, it's the patients with severe traumatic brain injury that are salvageable, and they have a bad CT. So our guy definitely qualifies. He needs a ventriculostomy. What we're asking, the question we're asking is, are there ICP issues going on? So if you have a bad CT and a poor GCS, you likely have ICP issues going on, greater than 60%. If your CT looks good, but your exam is poor, or you're posturing or hypotensive, you likely have ICP issues going on. So those patients will all benefit from a ventriculostomy. We know that fever is bad, so treat that fever if you can. What about therapeutic hypothermia? We're always asking the question, will therapeutic hypothermia help this case? The Eurotherm trial was published recently, and they looked at therapeutic hypothermia for TBI, and they showed no improvement in outcome. So the BTF guidelines say, no, it's not going to work. We recommend against it. The POLAR study, which is going on in Australia and New Zealand, should be wrapping up this year sometime. Maybe we'll have different answers from that study. But for now, no hypothermia. So if you had a ventriculostomy in, you could see the ICP numbers, and you're trying to treat that ICP, this is the tiered therapy that we go through. First of all, you recognize that the CPP should be 60 to 70. You're using mannitol, hypertonic saline, sodium bicarbonate. Maybe that helps. Next, you move to a ventriculostomy. That should help as well. But if you're headed to the OR like we were, that's when you want to hyperventilate. Push the PCO2 down to 25. If all of that's not working, vasoactives. Start a phenylephrine drip and push the mean arterial pressure up. This is what we do upstairs. Remember, you want to have the MAP greater than the ICP. And if that's not working, after you intubate the patient, put a rocuronium drip on. A paralytic may help. When you decrease the muscle tone in the whole body, you're also decreasing the tone in the brain, and it actually will help ICP. All of that having been said, you really need to go to the OR and do a craniectomy. I put phenobarbital burst suppression down there, but that's really the last thing, kitchen sink. We don't use that. There's a lot of side effects. So here's our patient. He went and got a craniectomy, and you can see how it helped him. The ventricles are open. He's got great gray-white differentiation. He did really well, got out of the hospital, and had a fairly good exam. So, in summary, avoid hypotension and hypoxia. Keep the head of the bed up. Take the airway if you need to. Otherwise, use it to follow the exam. Use the exam. Hyperventilate if you're really in extremis. Treat the fever, reverse the bleeding, and use osmotics and seizure prophylaxis. That's what you need to do. So, the other thing that happens up in New England in the winter is people put these ice houses out in the middle of the lake. And they get in the ice house, they cut a hole in the ice, and they hang out all day and they fish. This is what you're missing, those of you who live in Florida. That's why you live in Florida, right? Let's talk about acute ischemic stroke. We're going to go back in history and talk about where we've been, where we are, where we're going. It all started here, 1995, NINDS. Irrespective of how you feel about TPA, this was the beginning of our long and labored controversy. But then the retrievers came along, the Mercy, the Penumbra. And we were doing mechanical thrombectomy and clot retrieval. We were thinking this is going to be the answer. But in 2013, New England published all three of these studies that said, it doesn't work, it doesn't improve outcome. And that made the neurologists and the interventionalists and the neurosurgeons very nervous. It was palpable in our stroke conferences because this is their bread and butter. And if it can't show an improved outcome, it's not going to get FDA approval, and it's not going to get paid for, so it's probably going to go away. But then along came the stent retrievers. Stent retrievers penetrate the clot, expand the stent, pull the clot away from the wall, and you have reperfusion right then and there. Amazingly, they worked. Mr. Clean, the first study on that graph there, opened their books halfway through the trial and showed that they didn't need to finish the trial because the treatment arm was so much better than the control arm. When they opened their books, all the rest of those studies opened their books and said, wow, we don't need to finish our studies because this is clearly better and it's showing significantly improved outcome. This changed the world of stroke. Huge change in the world of stroke. Now we're focused on mechanical thrombectomy. How did they do that? Well, they focused on which patients would best benefit from this therapy. And it's the patients with the small ischemic core and a larger penumbra. The penumbra is tissue that's injured but can be salvaged and reperfused so that you're improving outcome. If you have a large ischemic core, you're not going to fix that with reperfusion. But you have an increased risk of bleeding. That can be converted into bleeding. And if you have a small penumbra, even if you salvage that, the exam's not going to change that much. So they said, we're only going to do this with patients who have a small core and a large penumbra. Makes sense. How did they figure that out? They used different studies. They used this. It's called the aspect score. Radiologist looks at the CAT scan, and you see all those numbers where it says M1, M2, IC, M3. Each area is is evaluated. If there's any abnormalities, like a loss of gray-white differentiation or a hyperdense MCA sign, you lose a point. High point is 10. The lower you go, the bigger the stroke. And they targeted the people who had the bigger strokes, because that's a big clot that you could likely retrieve with their mechanical tools. They used rapid software with CT and with MRI. And if you look at this, up on the top, the pink is the infarcted core. The green is the penumbra. So this top panel represents a patient that would be a really good candidate. But the bottom panel, you see that the core and the penumbra are the same size. That's not a good candidate. You risk conversion to bleeding, and you're not really salvaging that much penumbra. So that's how they showed improvement in outcome, choosing the right patients. This changed the guidelines. The guidelines then changed in 2015 to say, within 6 hours, it makes sense for us to use mechanical thrombectomy. I want to tell you about a quick case in 2013 before this all changed. I was on overnight. It was 3 in the morning, and this family woke up. The baby was trying to get out of bed, so Dad got up, went and took care of the baby, and came back to bed and notices that his wife hasn't woken up yet. And he's curious, like, she usually wakes up when the baby cries. And he goes and he sees that she's not moving her right side and she has vomited. So he calls EMS. They bring her in. She's got an NIH stroke scale of 15. And we get a CAT scan. And you see that there's no blood, but what you do see is a hyperdense MCA sign. Sometimes you can see this on a non-contrast CT, and it gives us a clue that there's a big old clot there. Then we did a CTA, and sure enough, we see the cutoff. She's got a big left MCA stroke right here. So I called our neurosurgeon. I said, Kethin, you might want to come in. This is a young woman. She's got a bad stroke scale. We're seeing a hyperdense MCA, and we're sending her to MRI. So he got up, and he came in. We did the MRI, and what you see here is on the DWI imaging, there's evidence of stroke where the arrows are, right? And on the FLAIR imaging, there's nothing. Now, FLAIR takes about 3 to 4 hours for a stroke to appear. So by looking at this, we can tell that she probably had her stroke within the past 3 or 4 hours. They went to bed at 8 o'clock. She woke up at 2. So she's a wake-up stroke. We don't know when it happened. We can't really give her TPA. But based on this, we sent her to angio, and he did a thrombectomy, pulled the clot out, and she had a wonderful recovery. She did really well. This study in Boston, called the MR Witness Trial, looked at just that. They said people who have wake-up strokes, we don't know when it happened because they're outside the window, but they're within 24 hours. They gave them TPA. And what they found is that it was feasible and safe. There's a lot more studies coming down the pike. Wake Up, ECAS4, and Extend are all looking at wake-up strokes and TPA. The Eyewitness is looking at wake-up strokes and using CT instead of MRI to figure that out. And the Dawn and the Positive are looking at thrombectomy in wake-up strokes. So this is the next thing that we're going to see coming down the pike, is being able to give TPA or do thrombectomy for patients who have wake-up strokes. So what's the important questions? Einstein said is the universe a friendly place? I think in this day and age, is the world a friendly place? But that's not what we're talking about. This is the next question. Here's a map of Maine. What you see is Bangor, Lewiston, and Portland. Those are our 3 tertiary care centers. And that's me. That's where my house is. Now, if I have my stroke, are you going to take me to the small hospital down the road and maybe give me TPA and then get me to a tertiary care center? By the way, the only tertiary care center is in Portland that does endovascular therapy for the entire state of Maine. So we have to figure out, what are we doing? If you wait and don't give me TPA and just ship me to Portland, then you're wasting that time. If you ship me to Portland and I have a smaller stroke and it's distal and it's not amenable to mechanical thrombectomy, then you wasted time. These are questions that we're asking now. So we have this is our screening criteria that EMS uses right now. It looks at facial grimace, grip, arm strength, speech. Any one of those in the setting of normal glucose is a stroke alert. Now we're starting to get more technical and more advanced scales, including the Los Angeles Motor Scale and the Race Stroke Scale, looking for large vessel occlusions. So we're going to try to triage. If you have a large vessel occlusion, we're going to try to get you to a center that can do thrombectomy. If you don't, then we'll go to the local hospital. Here's another question. Now that we can do thrombectomy and it's successful, do we need TPA anymore? Some people say yes, it can start breaking down the clot, and even if the person gets thrombectomy, there's no guarantee that you get that clot out, so the systemic TPA will help in the distal stroke. Other people say, no, we don't need it, it increases the risk of bleeding, and so we shouldn't be giving it anymore. That's a question that's being studied. The thing that we need to remember, and this is a new study that came out last year from our center that looked at missed strokes. And 22% of ischemic strokes were missed in our emergency department, not only by emergency medicine, but by neurology as well. And so the ones that were missed were mostly posterior strokes. So I wanted to say a word about posterior strokes. They're hard to find. They get mixed up with GI symptoms. So these are things that we should be aware of and just keep in our mind so we don't miss a posterior stroke. Young person with stroke, think about that. It does happen. If somebody's vomiting and they have GI symptoms and you don't have a unifying diagnosis, they may be having a stroke. Do the gait testing, do the heel to shin, do the Romberg. Look for nystagmus. CT is not good for looking at the posterior fossa. Here's a CAT scan that looks pretty darn good, doesn't it? I don't see any stroke there, I don't see any bleeding there. Here's the same patient with an MRI, and you can see the stroke. That's how glaring it is. Don't be fooled by a normal CAT scan if the patient has posterior signs. So, door-to needle time impacts outcome. Endovascular therapy is an option. Consider that posterior stroke, and we've got more data to come. So, it wasn't all work when I was up there. We went to the White Mountain National Forest. You can see how much snow there was because it was covering up the sign. We went for a nice cross-country ski, saw some beautiful things, shared lunch with the woodpeckers, and had a great day. Now I want to wrap up with intracerebral hemorrhage. And those of you who were here for Haney's talk, he covered a lot of this, so we'll go through this a little bit quickly. Again, Valentine's Day, St. Valentine's Day, while I was up playing in the woods, this guy came into our department, 68 years old, had been nauseous and vomiting the night before, thought it was GI, went to bed, got up the next morning and was worse. His wife brought him in to a hospital outside of ours, and he had this CAT scan. You can see that he's got a right basal ganglia bleed with intraventricular extension. Here's the bleed, here's the ventricle extension. So we think about intracerebral hemorrhage and the things that we need to do quickly and the things that we need to take our time with. First of all, do you need to intubate the patient? If they have an exam, you're going to take that away with intubation. So don't think that everybody needs to be intubated, but if they're not going to protect their airway and you're worried about it, intubate them. Be careful of the blood pressure. Blood pressure doesn't want to be high, we want it low. But how low do we want it? Well, I don't have a picture for you on that one. This is the ATTACK trial that Haney was talking about. What they showed is that pushing the blood pressure less than 140 is no better than pushing it less than 180. They're both safe. The way I stratify it is if I think or know that the patient lives up in the high blood pressure range, I'm going to use 180. If I think they're normotensive most of the time and their high blood pressure is from the bleed, I'm going to use 140. Remember, hemorrhagic stroke wants the blood pressure low, ischemic stroke wants it high. Reverse the anticoagulation. This is the case where you're going to use prothrombin complex concentrate. And this study showed us that clinically, prothrombin complex concentrate, or PCC, does work better than FFP. They went into the OR and they randomized people to PCC versus FFP, and they showed that clinically there was less bleeding. So not only do we bring the numbers down, but it works. And this is the patch study. This is where it applies. Don't give platelets, just empirically. If the platelet levels are super low, like less than 50, or if they're going into the OR, they can get platelets. But otherwise, they do worse if we give them. The NOACs, the novel oral anticoagulants, I have no new news for you. Just want to know which agent did they take and how long ago did they take it. And then lock and load into what you need to do to reverse those. So for intracerebral hemorrhage, protect the airway if you need to, manage that blood pressure, bring it down, reverse anticoagulation, and again, think about osmotic therapy and seizure prophylaxis if their exam isn't perfect. So I want to wrap up showing you some folks that we shared the trail with that day. And these are husky dogs that are being trained to pull a sled. And it's great because we heard them from at least a half a mile away. And what happens is they arrive in a truck and they have all their little huts. And you take them out of the truck and hook them up to the sled, but you can't let them take off. So there's an anchor to the sled. While they're waiting to take off, they are howling and you can hear it from miles away. And then all of a sudden, what you hear is silence because now they're running. And have you ever seen a happier face than these guys who are pulling a sled? It always gets me. So, in summary, for subarachnoid hemorrhage, understand your diagnostic tools. Don't miss that diagnosis. For TBI, the new guidelines, the most important one is let the blood pressure come up. And with acute ischemic stroke, endovascular therapy is bringing us new opportunities and new challenges. And with blood pressure and intracerebral hemorrhage, bring it down, use your judgment, and make the best choice. And with that, I thank you very much. And if you ever come up to Maine, please come and visit. I promise I won't make you shovel. Thank you.